Thank you. It's actually really a privilege to be here. It's kind of a tough gig to be here at the end of 2 days, but I'm going to try to do my best that I can. You know, all these things that you're going over, all this science and everything like that really has no value unless there's possibly some form of reimbursement. And what I hope to do today is to give you some of the foundations of how we'll use the term payers or insurance companies tend to look at things. I am Dirk Slaker. I'm a physician. I was originally, when practiced in gastroenterology and hepatology, I practiced at Emory until 2004. And unfortunately, at that time, I was working transplant hepatology, but that wasn't my problem. I ended up having a tractor accident and sustained a fairly significant cervical spinal injury. And that forced me into a bit of a recovery period. And then I kind of came back into the business of medicine. So I have a nice balance. I'm old, so I have a lot of years of experience behind me, both in the medical practice and in the insurance world. My talk has a little bit. So my current position, I serve as the National Medical Director for Optum Health Solutions. My role is that I'm tasked with oversight for Medicare and Medicaid, as well as several commercial clients, transplantation, ventricular assisted device, and CAR-T cellular therapy. I'll get up to speed with this. I really don't have anything to disclose, so nobody supports me, so everything I give you is my own opinion, and for the most part, biased only by me. What this slide goes to show you is basically what everybody's fear is about insurance. Option A is that if you have some kind of cardiac event, you get the defibrillator. If you have option B, it covers someone rubbing their feet on the carpet and touching you. And I think that really most of us have very ill will and bad opinions about insurance companies and payers. But by the end of this, I hope to show you that really that may not necessarily be all true. In terms of payer objectives, I think you'd be surprised, but really the payer wants to deliver right care, right time, right place, and the right provider. So, and you may not know what Optum is, but Optum is a part of United Healthcare. So under the umbrella of United Health Group, there is Optum, who I work for, which is a service provider. We're a medical service provider. And then there's United Healthcare, who actually pays the bills. Globally, we have 330,000 employees. And we're a Fortune 7 company, used to be a Fortune 5, but have taken some hits of late. So really, we are trying to provide quality care. And in that regards, we're not always trying to look for saving a buck, but we are trying to provide procedures that have a certain degree of science and support to make sure that what we're doing is correct. And in that space, too, we're looking at collaboration and not necessarily confrontation. I think over the last 10 to 20 years, there's been a real change. Actually, now we're engaged, and just before I came here, I was on a conference call talking about some posters that were being presented at a liver meeting, the national liver meetings in Washington, D.C. in November. And we had actually participated in these studies with several scientific institutions. In this case, it was Northwestern. So really, there is not as big a disconnect between the insurance or payer community and the scientific community. So, but what are we talking about? And this is what, when you're looking at services like ECMO, you're looking at this as a benefit. And a benefit must have certain principles associated with it. One, it's for prevention, evaluation, diagnosis, or treatment. So you want to make sure that it has that litmus test that it's held up to. An important part that we're going to come to later in discussing insurance benefits is that it can't be excluded in the benefit certificate. And what that means is really related to the type of plan or coverage you have. And we're going to talk about those that are, that are your traditional insurance plans versus the ones that are funded by the companies themselves. And then most importantly, whatever you're trying to call a benefit, it must be medically necessary. This will be a recurrent, a repetitive, and common theme throughout my talk is that concept of establishing medical necessity. And as I sat at dinner and lunch and some of the talks, you know, people are going, well, how are we going to get this reimbursed, and what's going to lead to this being an accepted principle? And at the core of that, at the root of that, is medical necessity. Did I go backwards? Okay, examples. Let me put all these up. So when we talk about benefit examples, we're talking about physician services. The doctor who spoke last night from Princeton, remarkable guy, he was talking about how he was going to get reimbursed for his physician services because he's working now as an independent contractor. So that's what a benefit is what services are covered for the physician. Surgical procedures, radiographic procedures, whether they be diagnostic or interventionals, laboratory studies, medications, and then something we're all concerned about is medical device or durable medical equipment. So all these things fall under the bailiwick of benefits, and that's what we're talking about here. So how do we determine medical necessity? What are the principles that establish something being medical necessary? The first is that there is an expectation that whatever you're doing is going to influence a treatment or a condition in terms of its outcome or course. So that device, that medication has to have some impact on the course of disease. The second thing, of course, is you want to prove something's safe, right? So it has to go through some form of safety trial or whatever and show that it's not doing more harm than good. It must meet the accepted standards of medicine, and in my next slide I'll talk a little bit more about that. And it can't be experimental and investigational, and that's a little tough road. How do we get there? How do we get that something's not experimental or investigational to that being some form of accepted standard? And that usually, and this is a whole nother discussion, is through clinical trials, right? So that's the step between getting you from experimental or investigational to being accepted as a standard of care. As I looked, there is a website that you could all go to. It's called clinicaltrials.gov, and it's all clinicaltrialstogether.gov. And if you go there, and I went yesterday and looked to see how many, there were 598 ongoing clinical trials if you use the search word ECMO. Okay, so that's how many clinical trials are in the works right now, with varying disorders and diagnoses attached to them. But so the step to get from that experimental is to accepted is through the clinical trial. So who helps set these standards? Whose regards? Well, as a payer, as an insurance company, we turn primarily to Medicare. And if you think about anything that Medicare will usually cover, an insurance company will cover as well. Of course, when you say Medicare, let's just say governmental agencies, and within that scope, we'll also use the FDA. So those things that are usually proven or approved by Medicare or the FDA usually will trickle down to the commercial payer and then subsequently Medicaid. Medicaid is usually the last line of business that will perform some kind of authorization of a device, treatment, et cetera. We also turn to medical societies, to medical guidelines and white papers. For instance, the American College of Cardiology, or ISHLT, the International Society of Heart and Lung Transplants, or the American Society of Transplant Surgeons. These are the organizations, so we will turn to them to look to help us establish what's medically necessary. And also in the scope of that would be non-for-profit organizations, the National Cancer Cooperative Alliance, which sets forth, you know, if you think about, good Lord, all the chemotherapeutic agents that are out there, and what NCCN does is gets subject matter experts in terms of oncologic therapies, and has available to the public very nice algorithms for undergoing cancer therapy. So, you know, for anybody that has cancer or knows anybody with cancer, the nccn.org is a great website to go to in terms of that. But the organizations like this will also provide us that. And then we also will turn to, you know, everybody says, you know, it's validated in scientific literature, but what we're talking about is current literature, current peer-reviewed scientific citations that are especially specific. In one of these abstracts I looked at today, they cited the World Journal of Gastroenterology. And I thought, you know what, if you're going to present an abstract and a poster, and that's what you're citing, you look for some trouble. That's not going to be an accepted gastroenterology. That's basically a journal that you can pay to have your article put in. So, you know, I'm talking, at least in the GI world, like gastroenterology is a journal put together, or hepatology. But we're looking for things that are in the main lane as far as scientific societies. And then we also will have expert panels. So if we're trying to develop protocols or strategies, we will have subject matter experts in whatever field, whether it be ventricular assist devices or whether it be liver transplant, that we'll actually bring together and have them give input on guidelines or strategies that we're trying to do as far as determining medical necessity. So what comes about out of this? What do you produce? What do we create? Well, this is from Aetna, one of our competitors, but you create a medical policy that describes what is medically necessary, all right? And basically we all have them. And most of the time, if you go to Dr. Google, you can search these things and you will be able to access this policy. This policy I actually pulled up through a Google search. So you could actually, you know, identify if you're trying to do something that may seem a little out of the norm, it may not be that for certain payers. So what I did for this discussion is I went through both Aetna, I went through Cigna, I went through Optum, and to a certain degree the Blues, to try and show you what they deem right now as being medically necessary for ECMO. Currently, we are a bit unique. Optum is a bit unique in United Healthcare in that they will approve ECMO for adult respiratory distress syndrome in the setting of COVID or without COVID. We have seen a large increase, as you might anticipate, in requests for lung transplantation in this COVID era. COVID can be quite devastating and lead to irreparable damage that requires lung transplantation as the only plan of care. So right now we have COVID lung, as we call it, with ARDS as a medically necessary. Short-term, bridge to heart-lung transplantation. I know these may seem things that are intuitive, but I just want to give you as far as what we as payers are willing to cover for you. One area that I'm in is VAD. ECMO is very prominent in VAD as far as cases that I review. And it's becoming part of what we call this non-durable mechanical circulatory support along the lines of other things like Centramag. I mean, IABP, balloon pumps are probably the earliest around that, but now you're seeing things like Centramag devices, Impella devices, and there's a whole spectrum going from the balloon pump to ECMO that are active treatments in VADs. A unique characteristic, VADs used to be thought of primarily as a bridge to transplant device, but now VAD is being seen as a long-term solution. It's called destination therapy. So you're seeing a higher number of patients being implanted with ventricular assist devices, which at this time the only one that's FDA approved is the HeartMate 3. Heartware was taken off the market. But you're going to see more and more patients that are walking around. There are patients out there with VADs now with the HeartMate 2s, probably in excess of 10 years. So when you're calling it durable, it is for all intents and purposes a durable and may offer an alternative to transplant in terms of some organ shortages. Following heart surgery to ease the transition from cardiopulmonary bypass to vent, non-necrotizing pneumonias, primary graft failure after heart-lung or heart-lung transplantation, which usually leads to a second transplant, pulmonary contusion, smoke inhalation injury, and then other reversible causes, of course, of respiratory or cardiac failure, such as cardiogenic shock and an increased arrhythmia burden, usually ventricular in origin. So again, these are extracted. I'm not saying these are all right or wrong. I'm trying to show you so you know what we as payers or insurance companies think in the setting of the big three or big four. So what's not covered? What is considered? Again, let's go back to what's experimental and investigational. Acute coronary syndromes. Within that, remember how I told you clinicaltrial.gov, within that 600 total trials ongoing, there was a significant fraction of those that were dedicated, because I looked, there's a break, you can do a breakdown by what the trial, other keywords in the trial, and acute coronary syndrome was by far one of the largest in ongoing clinical trials. Acute massive pulmonary embolism, aortic dissection, post-coronary artery bypass grafts, children undergoing abdominal. I'm not really quite sure why that is. Again, this was listed in to get on my list, it had to be in 3 out of the 4 that I mentioned to you. Drug overdose, obesity hypoventilation syndrome, pregnant and postpartum women with H1N1. I guess there must be a large number of requests for that, but I'd not seen much of that myself. And pulmonary embolism, cardiac arrest, and support during lung transplantation other than bridge. So the list of the yes and the almost equals the list of the no's, right? But you're all familiar with this. But it's really not to say, yeah, well, we knew that already. But this is, I'm trying to say to you, these are the things that even if you do them, your likelihood of reimbursement is going to be increased if you're doing them under the context of looking at these policies. So there are exceptions. There are exceptions to experimental investigational. One is sometimes the device, if there's a large influx of the cases that the FDA is seeing, people will go to them and they will be able to get an FDA humanitarian device exemption, which is basically to say, hey, look, we've got a large number of these cases ongoing. For right now, we're going to give this exemption for ECMO to be used for these postpartum H1N1s. So that's an extenuating circumstance, which could be, you know, a temporary but relatively quick acceptance of device usage. Life-threatening conditions. Insurance companies, and as you'll see from the next point, they hate to deny certain things in the life. And it makes sense. We shouldn't be, right? We shouldn't be saying, you know, this person's going to die in 2 weeks if we don't do this. And you will find that most payers or insurance companies will approve things is if you do the process to establish that it is in fact a life-threatening condition. And then there's always, 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 on a case-by-case basis, the individual consideration. And that's what I call the CNN principle. And what does that mean? Well, you probably already know, but this is an example of a case that was with Optum. Her only chance at life is a new liver, but her insurer says no. That's always a great headline, right? That's almost as exciting as a 60 Minutes van pulling up outside your house. So I would say those two things. Then she wrote a powerful plea to the CEO. Drop down. All Erica Zach wanted to do was play with her daughter on the playground, take her to the zoo, walk her to school. What kind of PR nightmare could you expect could be any worse than this? And it was. I mean, Optum and United Healthcare took a big hit for this. She eventually was listed for a liver, but unfortunately passed. The reason that she was denied originally the liver was that her condition was metastatic colon cancer. And for any of you that have worked in the medical setting, you're going, why would you transplant somebody with metastatic colon cancer? Well, the case is that it's now almost considered to be accepted in the case where what? It's limited to the liver, right? So you have to go through. But this was a sentinel case in this type of diagnosis and treatment, and individual consideration, life-threatening, should all have been taken into play before we ended up with this kind of coverage. So yes, it can be on a case-by-case basis for how you use something. So again, we could, like, we have some time for Q&A. I want you to ask your individual questions, but I don't think it's fair to, you can generate more educated questions if you understand everything about what payers are thinking, right? And so the most important part for a lot of procedures and a lot of use of equipment is prior authorization. What is prior authorization? The process that is required by the insurance carrier to request pre-approval, prior pre, for a procedure or service, okay? And I know that seems very easy to understand, but this step is so often eliminated and creates so much problems for you service providers down the road. Keynotes to it, you got to start early, okay? One of the key things to prior, if you're thinking you're going to be doing something, you need to say to the insurance company, you need to let them know, hey, this is what we're going to do, and request it early. COVID has only made all of the next steps that I'm going to show you worse. And the sense and the reason behind that is that hospitals and facilities have sent a lot of people home, okay? And one of the reasons to keep people at work sometimes is to watch people. Not everybody is meant to work from home. I mean, I've worked from home probably now 8 years, and I can tell you it wasn't an easy transition. I will tell you, I'm a musician and I have guitars in my room, and I sit there and sometimes I say, oh, it would be nice to play that song that I just heard on the radio. You have to have the right kind of mindset to work from home, not to be that distracted. So what we've done, and I'm not saying these people are not bright, but there are people that need to be working in a monitored setting. So trying to get authorizations, trying to get information has become very tedious and very difficult in this COVID phase, and made everything more difficult as far as authorization and reimbursement. Payer requests do not allow for all types of requests to be expedited. You may think it's an emergency, but unfortunately a payer may not. So again, that's a reason or a rationale to try to do things early. And on average, this can take up to, on average, things can take, if you're allowed an expedited, that usually means 72 hours. And if it's not expedited, a standard request is usually 30 days in insurance speak. When you're doing it, this may, again, all seem intuitive, but this is the exception instead of the rule. You want to submit with whatever process or whatever you're trying to get authorized a detailed letter of medical necessity. You want to really say what we're doing. Hey, we want to do ECMO. We think that we're having this patient population, or we're seeing these cases and we want to do it for here. You want to say that. You want to be as basic as possible early on. One of the things, again, you should realize that the first person probably that's going to touch this is not scientific or non-clinical. So when you're trying to request authorizations or approval, you want to be very clear in what it is. ECMO for, this for, CAR T-cell therapy for this line of cancer. You want to include that physician assessment. You know, our doctors have seen this patient. There is no other option. Let's just say it was a pediatric lung transplant. This patient requires this, and we're requesting authorization for it. Again, give information. Unfortunately, and we were talking about electronic health records, has anybody looked at a electronic health record and really tried to glean meaningful information? It's nearly impossible. It's all set up in this kind of algorithmic fashion that people really don't have to be smart. They don't really have to give opinions. And a lot of the things that you're requesting require that. They require, hey, look, these are the symptoms, this is the issue, and this is why we need the treatment. But that oftentimes is not the case, more often than not. And here I bring it up again, beware the EHR. I was on a call last night with somebody who was doing consulting for a major medical center in the Midwest, Cleveland Clinic. And they were looking at trying to help them be more efficient in the processing of claims and authorizations. And what they were saying was that they were getting sometimes for these reviews 200 pages of records on average. So the facility was back 17,000 claims. 17,000, okay? So one, you have people that are working from home that don't want to work. Two, then you're getting overloaded with records. And then they said that over 50% of those cases had duplicate records. So people weren't only sending 300 pages, they were sending 600 pages. So you're caught in this conundrum of having to look at all these records and trying to have people screen these at home while their 2-year-old got sent home from daycare with a runny nose, and what work's being done. So the inefficiency of this is really quite staggering. Why you need good coders? You need, well, besides test results and things like that, you need good coders, because coding will make you a lot of money, and if it's done correctly. So you want to have people that are clinical, and you want to have your coders and things like that, because doing coding, the number one reason that people don't get reimbursed other than incomplete medical records is coding errors. So, somebody that is well trained in coding and understands what's going on is great. And then any kind of testing, again, providing the records. And then supporting documentation. I said, be concise and complete. Provide things, relevant medical records, including, I don't care if they had hangnails, if there's a code. If you're doing 60 codes and you put a code, you're lost sometimes in this, nail fungus, hangnail, and then you're trying to extract those really important codes. And again, people are tired when they're looking at this, but the important part is to give it concise and complete. Concise and complete is very important there. And then you can provide your own citations. A good document or a request for prior authorization will include good peer-reviewed literature supporting what you're asking. And this will become important later. We can talk about it now, in that if you require a peer-to-peer, okay? And a peer-to-peer is that you're going to go as your clinician, as your provider, and you're going to talk to somebody at the insurance company, usually a medical director, and you're going to try to plead your case. And I spent 3 or 4 years in specialty drugs, and we have very strict things about how certain medications, especially in this era of these highly expensive immunologics and biologics, and I'll hurry. What am I looking time-wise, Matt, or are we good still? Yeah. Okay, all right, good. So, but they would come back with references. Let's say it was an oncologic drug, and they would give me something from, heme, which is hematology, which is one of the magazines. And I'd say, okay, that makes sense. Science will prove it. And if you really want to be smart, if you really want to be savvy, you bring their own policy to them. I'm not saying everybody really knows how to read the policy or look at the policy correctly that's doing the reviews. But I gave you some of the, for us, it's uhcprovider.com. uhcprovider.com, and you can go in there and you can put in keywords. You can put lung transplant or just put in transplantation. ECMO's a little harder to find in there, but you can put anything you want, and it'll pop up the policy. And it will give you a non-proprietary version of what we use as our clinical documents. So if you look right through here, you're looking at every way that you want to get your procedure, your treatment approved. This slide, we tried to kick it out, I'm sorry. We got it in there again. So what's going to happen a good part of the time, right? You're going to get this thing. You're going to get denial. You're going to say, hey, you know what, this doesn't meet our policy. Your treatment has been denied. There's 30 minutes. Remember how I told you we were going to come back to this? And just to briefly reiterate, traditional routes of insurance patients is called FI, or fully insured. That's what most of us have. If you have a standard Aetna policy, if you have a standard Blue Cross policy, you'll be, you pay your premium, and then we go through all that process to set up these policies. The other road is what we call ASOs, and that's where a company funds its employee benefit plan. One of the biggest ones in the Midwest is John Deere. John Deere has a lot of employees, and they have created their own coverage documents. And within that, they can say exactly how they want that policy to work or not. They can say that they won't approve ECMO for BADS, okay? That you can't have that form of non-durable mechanical circulatory support for BADS, and it's not going to be paid for. So there are many instances where these ASO plans, now again, it can go through an appeal and things like that, we'll talk about. But in that setting, you're going to go, well, that doesn't make sense. Well, they have the right because they're paying for the plan, and they're paying for the coverage. So if you're one of those plans, you really want to make sure, or if you have the option to enroll in a company plan, you really want to make sure, depending on your health, what's going to be covered and what's not. It's very important because you don't want to have these kind of problems down the road. What did I do? So we talked about denials, and here's the important part. I'm going to tell you three things: appeal, 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 appeal. Okay? Insurance companies like to deny at what we call first-line review. Okay? So when they first, no matter, maybe this all the information we said, you've done it all right, but there's still the chance that you're going to get denied. How high is that chance? I really can't tell you. I think it's independent by the payer. It's not that their intent is to do that, but they're going to be the strictest. Okay? So in that information, there's going to be somebody looking for check boxes, right? You had this, you had that, oh, you didn't have C. Okay, so you're going to be denied. Okay? And sometimes it can be something I saw that in the presenter before me, he had CTCL, which is cutaneous T-cell lymphoma. Okay, and I know for a fact I've reviewed cases, because I used to work Medicare appeals as well, where the reviewers didn't understand that that was a T-cell lymphoma because it was called CTCL. It's also called mycosis fungoides. But that didn't hit the checkbox, right, because it wasn't that T-cell lymphoma. So those are the kind of things that will trip you up on a first and will lead to that. And it's very important to appeal. So they can be performed pre-service or post-service. I would say the better part is to do your appeals pre-service, okay? Because if you do a post-service, then it's basically a claims appeal. And those can drag on forever. So you really want to do your work on the front end to make sure if you're going to do an appeal. There's a thing called a forfeit rule also with appeal. Appeals have deadlines, and it's always very important, if you're thinking about going down that road to appeal a service denial, that you make sure you understand what that is. Most of the time, it's 30 days. In expedited appeals, you have to submit that usually within 72 hours. So it's important to understand that, because past that point, and it's written in the language, it's written in the evidence of coverage that people have, that if you can appeal, but you need to meet the deadline, otherwise past that, there's no chance. And there is no chance. So what are we looking at in terms of appeal? Well, the first level appeal is usually within the insurance company, and that's a peer-to-peer. That's where either you, if you're a provider, you go to the company and you request to speak to the physician. I will tell you that the majority of physicians, so there's two groups of people that work for insurance companies as far as physicians. There are people who or basically had practiced medicine. They may have been really good at medicine, and then something happened that they decided they didn't want to do it. Maybe, you know, they just, like myself, I had a catastrophic injury and I needed to do something else. And then there's the other group that basically suck at doctors, at being doctors, and they think that going to work for an insurance company is going to be easier. Well, it's not. It's like working in a salt mine. When you're paying your dues, it is not fun to be a medical director at an insurance company, at least early on. I've been very, very fortunate. I had some specialty training. I was able to climb out of the ranks. But I will tell you, I have paid my dues. I have done my fair share in the past of reviews for diapers, for knee walkers, for home toilets. So I have paid my dues. So what I'm saying, why is that important to you? Well, you're a specialist. You have expertise in what you're doing. So what I'm saying is you may run into somebody who has no expertise, who has no understanding of what you're doing. So don't always have the expectation at the first line of review just because he's an MD, he's smart, or she, or them, one of those. But they're not necessarily going to be smart. The written appeal is also handled by a medical director, but usually that's the time when you can shine. That's when you come with your references. That's when you come and say, hey, I looked at this policy, and this is what your policy said. You should cover it. And usually you can get that approved. A third level appeal, hopefully you get it 1 or 2. And why I say that is that goes to an external vendor, okay? Supposedly experts. But now these experts are the same kind of experts that are the medical directors early on, right? You're going, why is a neurosurgeon doing these reviews, right? Why does he need that money? Well, he could be divorced like me twice, or he may not be that good of a neurosurgeon. Divorce is very costly. Yeah, he could be that. So why is that bad? Well, one, he works for an external vendor, right? We're paying them. So they're going to be very what? Are they going to approve it? Not very much, because they're getting paid primarily to give you no's. So they're going to spend a lot of time creating high-level rationale why they should approve your service. So try to get it approved either at the first level and or the second level. And why I was laughing, I'm not really that insane, but my wife works for OptumRx, and so we tend to do this road show, and so she gets all these things where, you know, she works in narcotics for OptumRx for government contracts, so she had a physician call her today in a quote peer-to-peer, just screaming, telling him how we all suck. It's just, so, you know, and I thought, the key to a peer-to-peer, having done peer-to-peers, is always disarm somebody at first, right? And she's really good at it. She's got this sweet Southern voice. So, but you don't want to come in hot. That's what I'm trying to tell you. You know, if the guy on the other end's going to say, "Oh, I'm not going to approve this." Interactions with humans is diminishing. So, but I'm saying try to be kind and try to, you know, just say, "Hey, look, I think this patient. I'd like to talk to you about my patient." So that's the point there. So first or second level appeals, try to win it with the doc. If you can't, win it by a good document, and don't try to get to the third level because your likelihood of success is low. Let's see if I can move my butt. I told you that already. It's the most stringent. They really stick. It really is a checkbox kind of approach to your appeal. A high likelihood of success, though, with your appeal. I forgot to talk about net provider score. Does anybody know what a net provider score is? Okay. So government thought it'd be a good idea, so to keep kind of a checks and balance with insurance companies, that they came up with making that insurance companies had to have this metric, net provider score, where the doctors get to say how good we're doing, right? So they give us a score, you know, a good score is 80% if they think the overall review. And Medicare uses that for reimbursements to insurance companies or to set up contracts with insurance companies. So that's what that could be your last result in the actual direct contact peer-to-peer. Well, you know what? I don't think, doctor, this is going to look very good on your net promoter score. Approved. No. But they do take that, you know, they're humans, and they're going to take that into consideration. So you do have a better line of success here. That's what I'm trying to say. Also is, if you do good with the first one and you've got to come back, eventually you're going to be talking to the same docs, or the same people are going to be doing it. So if you really put that time in to try and create a good document, something that they look at and go, you know, this doctor's pretty bright. He knows what he's talking about, knows our policy, knows the literature, knows his specialty, and do it. You come back, it's going to be 5 minutes. So you're going to save yourself time. Oh, yeah, hi, Dr. Slaker. It's good to talk to you again. Yes, yes, yeah, another great appeal. So, you know, people don't want to put the time in, and time is money, and it really makes sense in this kind of context. You have nothing to lose, nothing. If you get savvy at it, you have nothing to do. And as I said, you don't want to come back with the claims. I was looking at a claims review the other day. Sometimes, unfortunately, I have to look at these, and they'll ask us if this readmission is transplant related. This claim goes back, I looked at it, it was 2007, okay? So they're looking at services and contracts from so if that's not enough of an impetus for you to try to understand, to do this early and quickly, I don't think anything is. You're going, finally, his conclusions. We really do care, okay? I know, I want to tell you that. It doesn't sound like it all completely in there, but we really do. I'm fortunate in that I provide services, and I would say in terms of transplant and VAD, there really is less than 1% denial rate. And why would I even deny anything in transplant? Some of the problems is psychosocial, okay? Some of the problem is that a transplant's not an easy thing to go. I don't know if anybody's had a transplant. I bet somebody in here knows somebody who's had a transplant. But post-transplant care is complicated. Same with VADs. Post-VAD care, we've got some buddies here who know about that, is complicated. And if you don't have the right caretakers, you know, really somebody shouldn't be getting a VAD. A lot of people, I mean, we even have requests for VADs. You know, a VAD requires a 3-prong plug, right? And we had a VAD request, and I looked at the psychosocial review, and they said the member didn't have a 3-prong plug. This was in rural Texas, in his house. How am I going to approve a $400,000 piece of equipment? The facility went nuts on me, and I said, hey, you need to look at what your social worker wrote, because what's that machine going to do? It's going to be no help to the patient who has, you know, an ejection fraction of 10%, who's on home IV, milrinone and such. So I'm just saying, you know, that may be, but really most of the time we're really trying to do the right thing. And we look for science. We really look for the foundation, that scientific foundation before, whether it's established or it's in a clinical trial, to drive that medical necessity, which we consider so important. And we do look to collaborate. I mean, you can come to Optum and say, hey, look, we think ECMO should be improved by your company for this indication. You can come to us, and we're constantly amending our policies. And when I say Optum, UHC policies, because our policies are UHC policies. And then attitude and effort. My son plays professional hockey. He's not in the NHL, but he's in the AHL, and he played 4 years at Michigan. And from a young age, I told him he wasn't the fastest skater. He's not the biggest, but I told him it was attitude and effort. And until he lost that, he could keep playing, right? And he's done that. And now he's a great skater because he's worked at it. And he's not big, but he'll knock your teeth out. But so really, getting the right people to work with you, collaboration, and doing the work will really lead to good outcomes. I know people hate us. They talk about insurance companies, make bad jokes about us all the time. And but you really can work with it. Don't look at it so adversarial, but look at it as collaboration, where if you do a few things and are smart about it, you'll get what you need, and that's the reimbursement that you deserve. So that's my hometown. That's Nashville. That's where I live now. And I just want to thank you all for really, at the end of the day, listening to me pontificate about the payer's perspective. So, thank you.